response imaging, and we'll move on to the audiologist who will show you how that is done. We are placing the head coil. We're placing the head coil on the implant, and the cameraman has to go to the laptop. Cameraman to the laptop is ahead, so that the audiologist and a microphone there to the audiologist. We have the audiologist in the operation theatre who will tell you what they're doing when they're doing the telemetry. While they're doing that, I will begin to close the book. And then if there are any surgical related questions, I'll answer.
Hey, good afternoon. Can you hear me?
Now the operation is nearly complete. Only the closer part is left.
Can you hear me, the auditorium?
Soft tissue will be closed,
Okay, I'm Ajin Shah from Advanced Bionics.
and the external device will
Now you can
be
see the cell has
placed
inserted, and then
subsequently.
here you can see there is a lock. That means the implant has started communicating. So now the first thing what we'll be measuring will be the impedance. So here we are measuring the impedance of the electrode. Before inserting the implant, we'll actually check the integrity of the device to make sure that the implant is working fine. And these are the first recordings that we got, which show that the implant is absolutely fine. And this is the first impedance measurement which we got, which showed excellent impedance. Other than electrode number 4, maybe due to some air bubble or something inside the cochlea. So there's an option of doing conditioning to bring down the impedance, which is what we are measuring now. So once that is also done, now we can see that all impedances are in place. For example, even the air bubble has gone down compared to the previous measurement. Now all the 16 electrodes here are having well impedance on an average of maybe 3 to 4, which is excellent impedance. Now we'll move on to the intraoperative measurements. We call it as NRI measurements. And then we'll start a new measurement. Like Sir was telling, we have 16 intracochlear electrodes. So we will be doing on 4 electrodes. So I'm starting with electrode number 3 as a stimulating electrode and recording through electrode number 1, which is on the apex. Now I'll be starting up with a little high current of 300 charge and maybe a little low up to 100. And so once we start the measurement, here on the left corner of the screen, you can see the measurement will start coming up. Now I'm having a little of you can see the response coming in. And there's a regression line which is forming, which is showing the growth in the nerve. The monopolar is on. So we'll be measuring at different current levels. You can see the response going lower. Show another recording. There's a little artifact you're seeing because there's also switching the device, so the tissue is moving. So when the tissue moves, it creates a little of noisy recordings. Otherwise, there's a huge potential. These are the 2 peaks which we look in. A negative peak called N1, and there's a positive peak called P2. That's a nice amplitude growth we're having on the recorder. Normative value for P1. Especially we look into the amplitude of the peak. For example, now this switch is a little noisy. Anything above 20 will be considered up to around 250. So here you can see the potential is around 192. And then here is 167. And it's coming lower because the lower the levels you come up, the response will also become lower and lower. As you can see on all these plots, we started from 400 and we're going down to 200. So the lower we came, the response came lower and lower. So now we have done on electrode number 3 in the effects. So I'll be moving to a medial electrode, electrode number 7. And then starting the That's a nice response. What do you have? Yes, you're doing good, sir. A nice response.
Yes.
A little bit of noise because of the tissue moving. That's all. So you can see a nice regression line. Again, and a nice amplitude growth between the levels. Yeah.
एक सेकंड के लिए माइक्रोस्कोप पिक्चर दे दो. Okay. Just use your mic. So keep it there. Bring it close to me. While the LRIs are going on, I just brought the picture on the screen to show you how this flap closes. So you have a nice closure. Okay? And then the skin will come over it, and the two incisions will not overlap. Can you see that?
Yes.
Yeah.
Yes.
Back to it.
Yes.
So over here we can see that machine has also been completed.
Top right.
So now we'll be going to the next set of electrodes, which is electrode number 11. So basically we have been checking the apical ones, the medial ones and the basal ones to make sure that we have nice response on all the nerves.
क्या नाम है? सात बासु. हाँ हाँ. 378. हाँ हाँ. लगभग 3-3:30 बजे आऊँगा. हाँ हाँ. ठीक अभी है. ठीक. उनका नंबर कितना है? सात बासु का. सात बासु का नंबर कितना है?
Now that has been done on electrode number 11. Yeah, it's unlocked. It came off. Yeah. Now we'll be doing the last electrode, most basal one, which is electrode number 15.
And now a recording is being done by giving stimulus to that implant so that his properly brain mapping can be done to make it more effective hearing improvement. So audiologist is on the job. Now it's showing in different levels of recording through the computer and the stimulus given and recorded so that response can be analyzed in a proper way.
You can see a good response even on the basal electrode.
So audiologist is giving the opinion that the response is excellent. That means the electrode is in proper place and it is functioning nicely. The response given from outside is adequate. We hope that the child will pick up very fast and his hearing level will improve. So
Do you want to quickly go through the CT scan?
Yes, please.
Yeah, okay. We go through the CT and MRI. The NRI is almost done. We're getting good responses across the electrode array. So no concerns there. Can you hear me?
Yes, we can hear you.
Yeah, okay. Sister, एक needle है ना? Lamba. Thank you. So, Dave, any questions from the audience about the surgical steps, the instrumentation, anything like that before I move on to the imaging?
Yeah, 1 minute please. Any questions please from the audience? No, none. Go ahead.
None from the audience.
Just a minute. What are the other electrodes? These are 16 electrode here. What are the
So you
other?
saw that I see for the purpose of cochleostomy, if you have access to the Zomed Skeeter burr, that's very good. It's a slow speed burr. I use it all the time for my stapes surgery.
Amit, the question asked from the audience is, what are the other electrodes? You mentioned about 16 electrodes. Would you include that in your lecture?
What do you mean by other electrodes?
It's 21 channel.
Others like 21 channel, 9 channel.
Different arrays, yeah.
Different arrays.
Yeah, I can address it later on. It's not, I wasn't going to talk about that, but there are different companies that produce implants, and they all have different design philosophies. So the advanced bionics has, 16 electrodes. Medel has 12 pairs of electrodes. Nucleus has 22 active and 2 ground, so that's 22 electrodes. So it's that's what it is really. It's dependent on the design philosophy of the company.
Right. Abhishek, who's going to represent Advanced Bionics, he said he's going to do a presentation afterwards.
Okay, good.
Okay.
Good, yeah. So, I think you've seen all the surgery steps. As an instrumentation, they have an insertion tool, which makes it easy. What I was saying is that in this case, you've seen I use a Skeeter burr. If you have a Skeeter burr, it's a great tool to have. I use it for all my stapes surgery, the Medtronic Zomed Skeeter. So you can use that. If you don't, then on a straight or an angled handpiece, you can use a 1 mm, 0.7 mm burr to make your cochleostomy. The advantage of the Skeeter is very slim. It doesn't come in the way. So certainly, worth looking at. The drills, we have a high speed. I had the good fortune, thanks to Zomed, for letting us use the Visio drill. So that's a high speed. We were operating at 50,000 RPM. That makes it quite quick. Okay, so CT scan. Very quickly, I'll run through the CT scan. This is an axial CT, as you can see, and we are going from inferior to superior. I'll quickly run through the landmarks. This is normal anatomy. We'll say let's concentrate on the right side. So this is the aortic canal, the middle ear space, the aortic capsule bone. This is the carotid artery. This is the jugular bulb, sigmoid sinus junction, and the jugular bulb here. We move up further. We come through the basal turn of the cochlea. You can see the basal turn of the cochlea here. You see the eustachian tube there, the little air space here. Okay, you begin to see some of the mastoid air cells in this diploid mastor here. So this is the basal turn. This is the round window. You can see the round window niche. You see the membrane. This is the middle turn of the cochlea. This is the tendon of the tensor tympani. You begin to see the malleus and the long process of the incus here. Okay, and this is the sinus tympani facial recess region here. We come further up again. You can see the basal turn, the round window. You will see the middle turn of the cochlea, again the malleus incus, and the facial recess here. We come further up, the middle and apical turns. You're losing the basal turn now. That's the middle and apical turn, tensor tympani, the tendon of the tensor tympani attaching to the neck of the malleus, long process of the incus there, and mastoid pneumatized air cells here. Come further up. This is the beginning of the vestibule. This is the oval window. There, you can't really see the stapes superstructure, but that's probably the head of the stapes. That's the oval window. Middle and apical terms of the cochlea. Vestibule, posterior semicircular canal is there. Okay? Facial recess, sinus tympani. This is where the facial stapedius. This is the pyramid. Okay, this is where the pyramid is. We come further up, posterior semicircular canal, see the vestibule better, see the internal auditory canal, middle turn of the cochlea, the head of the malleus, body of the incus, so-called right cone appearance, antrum, aditus, and you begin to see a bit of the facial nerve there, because we're just superior to the oval window. That's the posterior semicircular canal, vestibular aqueduct. So vestibular aqueduct there, vestibule, we are now cutting the middle turn of the cochlea, facial nerve is there. That's part of the posterior semicircular canal cut across its axis. We come further up, this is the lateral semicircular canal from the vestibule, internal auditory meatus. This is where the facial nerve will come into the middle ear, the posterior semicircular canal, middle of the vestibular aqueduct here. Now we are supracochlear, superior semicircular canal, posterior canal, middle of the internal canal, internal auditory meatus here, pneumatized mastoid. Then we come further up, we just have the semicircular canal. So when I do that, I look at everything. I look at the mastoid pneumatization, I look at the middle ear, I look at the cochlea, of course, I look at the internal auditory canal, I look for intracochlear ossification, pneumatization, estimate the size of the facial recess area. It gives me an idea of how easy or difficult it might be for my posterior tympanotomy approach. The position of the sigmoid sinus, if it's very far forward, again, can suggest it's a contracted mastoid and may make it difficult. Move to the MRI. So this is a T2 weighted MRI, again axial, taken through the temporal bone area, and so we are moving here from superior to inferior. Now here you can see the posterior semicircular canal. Okay, this is the point of the superior semicircular canal. This is the ampullary end, the non-ampullary end of the posterior canal, of the superior canal, joining the non-ampullary end of the posterior canal. So that's the crus commune. Yeah, this is basically on the MR. I'm looking at the fluid signal in the cochlea. I'm looking at the auditory nerve. I'm looking at the brain stem. So we come further inferiorly, and we begin to see the nerves traveling through the internal auditory canal, vestibule, lateral canal, a bit of the cochlea, and we see the nerves here. Now we will see a pair of nerves in the superior compartment, and then you will see a pair of nerves in the inferior compartment of the internal auditory canal. This is better visualized on the parasagittal section, like that, where you see 4 dots. So we know that in the superior compartment you've got the facial and the superior vestibular, and in the inferior compartment you've got the cochlear and the inferior vestibular. And what is important to note is that in the superior compartment the 2 nerves are quite parallel. You see that? These 2 nerves are parallel. In the inferior compartment the 2 nerves diverge. This is going into the cochlea. Okay, so you see this is going into the cochlea, this is going into the vestibule. So we've got good fluid signal in the cochlea there, in the basal turn. We can see the cochlear nerve, a nice cochlear nerve going into the cochlea, inferior vestibular nerve, the IAM, that's of course vestibule lateral canal. And that again is the cochlea, the basal and the middle turn. You see the cochlear nerve going in there, and that's important for you. And the scans to the brain stem and the brain don't show any obvious anomaly. This anatomy is important. The brain stem, if when I'm doing an auditory brain stem implant, discuss that briefly, then I need to look at this area, at the regional foramen of Luschka, the floor of the 4th ventricle, because that's the point where I'm going to place my my auditory brain stem implant. So that's what we see on the MR and on the CT. This is the parasagittal section I was telling you about. So in this parasagittal section of the IAM, again T2 weighted, so the nerves look black, fluid is white, and you see the 4 dots of the 7th nerve, the superior vestibular, the cochlear and the inferior vestibular. This has been marked out very nicely by the radiologist. So you can see these 4 dots, and that's what you want to see. So that's a quick run through imaging. And any questions at that, then I can answer them now. Otherwise, I will come down and join you and move on with my talk. Any questions? Dave?
Yeah, any questions from the audience?
Amit, one question from me. I'm Dr. Rai Chaudhary.
Sir.
Actually, when I was telling about the CT scan, CT scan. Could you hear me?
Yes, I can hear you, sir. Loud, please.
CT scan, because in one of our cases we failed to find out the round window while we are going for this cochlear implant surgery. And for after that, we actually asked for giving the measurement and show us the oval and round windows in CT scan. And do you find any importance for that or not?
No, what I do, I don't look for the size of the round window. We've never measured that. Sometimes, yes, you can ask them to measure the length of the cochlea if you want, because if you're using a metal device and you want to know how deep the cochlea is and whether you can use a standard array or a short array, then you can get an oblique reconstruction, and you can, like this, and you can get them to measure the length of the cochlear duct. As far as the round window is concerned, what I do look at is the orientation of the cochlea vis-a-vis the orientation of the external auditory canal at my axis, because there is this concept, true or otherwise, of the so-called rotated cochlea, which can make it difficult in small children to identify the round windows through a posterior tympanotomy approach, because the orientation or axis of the cochlea and thus the round window may not be in line with your axis from here to the posterior tympanotomy. So if you have a cochlea which is sort of in a position like this, then this angle is a little more vertical, thereby the round window is tucked in more posteriorly. So when we are going in like so, we can have difficulty visualizing it, and in which case you have to thin the external canal, you have to come down onto the facial nerve and look over the facial nerve, if you like, to identify that for a round window which may be hidden. I've not, unless it's an ossified cochlea where I expect that the round window will be ossified. I have in one situation of anomalies had a situation, a child with no round window. There was only an oval window, a very hypoplastic cochlea. So that was clearly abnormal on the CT, and we picked that up, and I knew that child will not have a round window, so I didn't even go looking for it. So that was a hypoplastic, type 2 hypoplastic cochlea, in which case I inserted, it was a single cavity hypoplastic cochlea, so there isn't intracochlear partitioning, it's all one cavity, and in which case I inserted the array through the oval window, because it doesn't make a difference there.
Now, in fact, what happens is if you ask for that, they reconstruct and show you the round window and oval windows in cities. And regarding MRI, do you give importance for the facial knob? You have not mentioned showing the facial knob, the course of the facial knob. And another point, the end-on view of the internal auditory meatus, so that you can see all the 4 knobs there.
Yeah, I showed you the parasagittal view of the IAM to show all the 4 nerves. That is important. That we saw here. So we saw that, all the 4 nerves. Is that what you're talking about?
Yes,
sir?
yes.
So we talked about that, and yes, of course, facial nerve. It's a good idea if your radiologist can do that on the CT, on the MR, or even on the CT scan. If you can see the course of the, I do that on the CT scan. I look at the course of the facial nerve, because again, it tells me how much space I'm going to have into the facial recess. So yeah, facial nerve, identifying the course is a good idea.
Thank you.